Next up, we've got Cathy Forbes. Cathy is an advanced specialist dietitian with the Food First project lead. And I'm going to hand over to Cathy.
Lovely. Right, I'm going to talk to you today about how we tackled the problem of malnutrition and dehydration in our local community, which is Bedfordshire, particularly Luton and South Bedfordshire. It's a population of about 400,000 people. We're talking about 55 care homes with over 10 beds, so about 2,500 residents. And we're talking about 52 GP surgeries, just so you can kind of put that into context. Now, food and drink, most people would think of as a basic human right, but it's a lot more than that. There's a lot of enjoyment which is linked up with eating and drinking. People probably can just think back to tea break earlier today or their lunch. There was some pleasure in that. But there's also a massive link with patient safety. So people who are malnourished and dehydrated are more likely to fall over, and that's because of the side effects of dehydration, so the lightheadedness, the dizziness, the hypertension, it's the muscle weakness, it's the instability. They're also more likely to get a pressure ulcer, and that's because they haven't got any padding either over their bony points or over sort of, say, where your bum is, where you should be having some nice fat to sit on if there's nothing there. And then wound healing is actually delayed, because if you're dehydrated, you've got lower oxygen levels to get to your tissues, and you've also got less nutrients circulating. Dehydration also increases the risk of blood clots and UTIs, so therefore they are a secondary driver in all those harms that are collected on the patient's safety thermometer. And as a result, people who are malnourished and dehydrated generally don't do very well. They tend to go into hospital, they see their GPs, and ultimately they also have higher mortality rates. Now, because it's a secondary driver, the costs are across lots of parts of healthcare, and it's quite difficult to identify what savings we can make out of improving malnutrition and dehydration, unless you look specifically at the prescribed oral nutritional supplements which are used to treat malnutrition. And that's a really clear budget, that's a prescribing budget. Until fairly recently, nationally it was increasing 11% year on year. And that's where our work was funded out of. Now, what we said was, yes, we could switch to a cheaper product. Yes, there probably are people who are being prescribed these supplements unnecessarily, but actually this is an opportunity for us to not just look at reducing the costs, but actually to look at the quality and tackle the root causes of why people were malnourished and dehydrated. And in that way, we'll reduce the spend from your prescribing budget, but we can also have an impact across some of the other healthcare budgets locally. And that was about 3.5 years ago. I have to think really carefully. And at that point, it was just me, 2 days a week. There's now a team of 8, which shows that we were successful. What we've done is we've been able to borrow some money from elsewhere and redesign our services. And when we started, only 43% of our care homes were actually using a validated screening tool to identify if people were at risk of malnutrition. For the first year, none of our care homes were doing it correctly. There were errors, always. Now, 75% are not just using, 100% are using a validated screening tool monthly, and 75% of them are doing it correctly and have got an appropriate plan associated with us. There was also quite a big debate in the dietetic world, and I appreciate if you're not a dietitian, it's probably not something you're aware of, but basically the idea is that food doesn't work. It has to be a prescribed supplement. That's the only thing that has any evidence. We started to be able to collect some evidence to show that food does work. 80% of the people that we met, that we created an individualised plan using food alone, have actually managed to maintain or increase their weight. So there's been a real benefit from there. And we've also got more people thinking about malnutrition and dehydration. I mean, the fact that I'm here today is really beneficial, but also we've been in the newspaper, we've been on the television, and we've got people just starting to think, okay, this person isn't eating well, I need to do something about it, and I need to do something about it early. Otherwise, there's going to be problems as we go further down the line. One of the other big problems was that there was no tool for looking at dehydration. So how do you identify those people who are at risk of dehydration? So how can you make a plan to manage it? we were involved in a sequin, which has actually looked at creating a tool. It's not validated, but it's very simple. It's worked on the same principles that we've done everything else, which is looking at what are the gaps and how do we fill them. So it's given us something else. And the good news is we made our savings. We are still being funded off the back of those initial savings. Particularly in the care homes, we've had a 6 to 7% reduction in the use of these oral nutritional supplements. So that's why I can actually be here today. So how did we do it? Well, we got people engaged. So starting off, met with members of care teams. So we're talking about nursing staff, we're talking about catering staff, met with our GPs. What were the priorities? What were the gaps? What was needed from us? And then we went, well, me on 2 days a week, even with 8 of us, is not going to be enough. So we had to empower other people to deliver our message. And that's been a real key thing. The other thing is that we reward people when they're doing well. Very rarely in the NHS, and it's probably the same across the world, do people say in healthcare when things have gone well. They point out when things have gone badly, or when things have gone badly and someone swooped in and rescued it. We focused on people getting it right every day. That boring bit where the person doesn't get dehydrated or malnourished and has to sort of be rescued, just getting it right every day. And when people aren't getting it right, we do find ways of encouraging them to change. So, for example, if we're working with a care home and they're not working with us, we will go to their regional office, we'll go to their national office if we need to, we'll go to the Care Quality Commission as the overarching organisation, and we'll go to the council. And we did that with one of our care homes, one of the worst that didn't work. They just were not meeting the nutritional needs of their residents at all. And now I'd say they're one of our glowing homes that do the best. But we've also had, key thing was getting things consistent. Our message does not change. It doesn't matter whether you're in your own home, whether you're in a care home, whether you're seeing the GP, whether you're seeing a dietitian, whether you're seeing rehab and enablement team, whether you're seeing community nurse, it's the same message. And we've kept things really practical. Now, usually I walk around with actual physical examples, but then someone pointed out I could take some pictures. So, I don't have little plastic boxes of food, but all of these are 100 calories. Not 100 calories in total, I'm afraid to say, but each of these are 100 calories. Now, there are lots of different 100-calorie ideas, and it's just putting it into something that people can actually see and understand. And the same with hydration. A lot of people who are dehydrated, they don't want to drink more. They're worried about having to go to the toilet. If you put a big glass of water in someone who doesn't enjoy drinking, that's going to be a massive thing to kind of overcome. So we talk about using foods. And my boss, her favourite thing is the fact that a boiled egg contains 40 mils of fluid. Now, when you think about a boiled egg, that's solid, so you don't imagine it's going to have any fluid in it. But you start to add all those up, and you add up everything that's in there, and you're looking at there being over to about 250 millilitres, which is actually bigger than the little glasses that you can see on the table over there. So if you wanted to put this into place in your own area, which I'd obviously strongly recommend because it's worked well, the first step is to agree best practice. Now, that may be different depending on where you are, either in the UK, and there are differences between Northern Ireland and England, but also where you are in the world. Then you need to review current practice and compare it with that best practice. What are the gaps, and what are you going to need to do to resolve them? So for us, we needed to put into place a training programme, and we also needed to put into place resources that people could use. And then it's delivering that programme, and it needs to be targeted at who you actually want to get to. So for us, our GPs had a very big concern about the care homes, so that's where we started putting our work into. There's also a lot out there about carers who go into people in their own homes, and we've rolled out our work to cover them. Now, they're people who don't really have an awful lot of training, but they have a great opportunity, especially if they're going into someone's home 4 times a day or doing their shopping for them, to actually just put that glass of water close to them, or buy them one of those 100-calorie boosters when they go out shopping. And then you need to go back and you need to re-review practices. And as I say, reward if it's going well. So we give our care homes a certificate that they can put up to display in their foyer so that everybody coming in can see that they have met our very high standards. Or if not, need to look at what can you do to change practice back. So is it that you need to sit down and have some one-to-one training? Do you need to call in some assistance? Is it just that all the staff have left and you need to do the training all over again from the beginning? And then because bad behaviour always creeps back, you have to keep going. So we go back on a 6-monthly basis to our care homes to keep re-reviewing the practice. Some of our homes, we have to take their certificates away. I've had to write after 1 month to say that if they don't behave, I will be removing it. And that's usually enough to prompt people to make that change, because they've had to work very hard to get it, and they do value it. And basically, that leaves me with about 10 seconds for you to just look at how you can get in touch with us. If you would like to find out more information, we've made our resources pretty available. So if you go to the website, which is part of our Trust website, you'll find a selection on there for you. Thanks very much.